This talk today is by request. Everybody wanted to know, and it's given by two experts in the area at our own DOH. And one of them I call the data god, or the data king, because he always has the answers to questions. So let me turn it over to Summer to introduce you guys officially. Do you have to show that slide?
I did, and I just lost it. I'm happy to see everyone, and thank you for being here with us. We are so grateful to have Dr. Galanis. Is my title slide up?
It's up.
Dr. Galanis and Tiana Fontanilla from the Hawaii State Department of Health sharing with us on our local opioid and fentanyl update. They will both be sharing, so I will turn it over to them. Mahalo for being here.
Thanks, Summer. Thank you, Kelly. Thank you, everyone, for being here. I know I'm going to switch up the order just a bit. I think it kind of frames it a little better. I pulled in, I know that the focus is on fentanyl and opioids, but I tried to bring in some of the co-occurring statistics. So I'll try to introduce a little bit from the SAMHSA National Survey on Drug Use and Health first, and then kind of tone it down on a more local view of the data that I can see, and then I'll hand it off to Dan. So a lot of it will be on the co-occurring mental health substance use disorder. I'll try to pull what I can specific to opioids, but let me go ahead and okay, you can see that there. Sorry if things come through the chat. I may not be able to be coordinated to see both.
I'll read the chat to you, don't worry.
Thank you, thank you. Okay, so just a quick, so I've been with the Adult Mental Health Division, I think since September of last year, but for a couple years prior to that through CDC Foundation and University of Hawaii, I've been on the Overdose Data to Action Project. I've worked closely with Dan Galanis here, and some of you on the call here today. So thank you again for joining. So I want to start off here with looking at substance use. So SAMHSA, through their National Survey on Drug Use and Health, NESDA, this is the annual survey done nationwide that is surveying on substance use and behavioral health indicators, but they looked at past month substance use among people aged 12 and older. And we see here with alcohol and tobacco products in the lead here, along with marijuana. So I'm going to just kind of speed through here for the sake of time. I have quite a bit of slides, but these are some of the statistics that I found from a call where they introduced the latest results from 2021. Zoning in on illicit drug use among the same age group, we have 21.9% who are reporting illicit drug use in the past year. Again, marijuana up top, followed by prescription pain relievers, specifically looking at misuse. And when we look at past year illicit drug use by age category, you can see that the 18 to 25 young adult age group comes in the lead when we're looking at the percent who has been using in the past year. So we see that overall for all illicit drug use, and then as well as marijuana use. Same for cocaine. We have the older age group population for heroin. And then we notice the higher percent in the lead, so that there's a change in the y-axis here slightly. But seeing that same age group, young adult, 18 to 25 years old, in the lead at 7.1% for hallucinogen use. And then for inhalant use, the age group in the running is 12 to 17 years of age. And then they also ask about prescription misuse. And this is looking at, by age category as well as type of prescription, so stimulant misuse, tranquilizer or sedative misuse, that would include benzodiazepines, as well as prescription pain reliever misuse. So we see in the stimulant misuse, that 18 to 25-year-old category has the highest percent using in the past year. We see the same thing in the tranquilizer or sedative misuse category. And then with pain reliever, obviously here it's 12 to 17 being the lowest, and then we have around that 3 to 3.3% using in the past year for our other age groups, with the highest age group in the lead there at 3.3%.
Is that supposed to be 12 and under? Or is...
Oh no, 12 and older. So the blue bar there, I'm sorry, the dark is this like gray or indigo there is actually all age categories.
Oh.
12 or older. That's all together.
Oh, Claire says the 18 to 25-year-olds are partying.
If we're zoning in a little bit closer to the prescription pain relievers, looking specifically at past year misuse, and maybe I should pause here. You can look at the annual report for a little bit more detailed information, but the NESDA had asked about prescription use as well as misuse. So just kind of noting that difference here, misuse being where they're taking that medication or that prescription not directed by a doctor. So anything outside of the doctor's directions would be classified as misuse. So if we're looking at this, let's see, among the ages 12 or older population who have reported misusing any other prescription pain relievers, we see hydrocodone, oxycodone, and codeine up at the top, with hydrocodone being nearly 47% among these past year misusers of any pain relievers. This is looking specifically at the prescription pain reliever subtype, right? So in this last one, we're just looking at the denominator of the pool being anyone who has reported past year misuse of any pain reliever, but this one is really zoning in at that specific pain reliever subtype. So we see 22.2% among past year users of buprenorphine reporting that they misused that in the past year, versus 77.8% reporting use but not misuse. So you can see that their buprenorphine is up at the top, the lead for the proportion for misuse, followed by fentanyl and oxymorphone. And then we have morphine all the way at the bottom here. And then they reported some statistics on the past year opioid misuse. So this would pertain to those who are ages 12 and older. 9.2 million people were reporting past year opioid misuse, with 94.3% reporting opioid misuse, specific to pain reliever misuse. And then we have 11.9% reporting specifically heroin use. And then noting that overlap in the green, 6.2% of them reporting both pain reliever misuse and heroin use. Looking at the percentage of disorders in past year, so NESDA will classify per the DSM criteria here. So much less just reporting on the use, but this is inferring that sort of longer term use and this disorder for the criteria. This is showing by substance type as well as age category. We have 14.4% reporting marijuana use disorder within the past year. And then 2.0 for the 26 and older when we're looking at pain reliever use disorder. And then finally, methamphetamine use. Slightly lower percentages, of course, compared to our marijuana use disorder. 26 and older slightly in the lead, but all floating around in that just under 1%. And I'm just kind of cherry picking here. So there's so much more that and I'm sure a lot of you are familiar with the NESDA statistics, but so that's a little bit on the substance use disorders. I'm starting to bring in now more of the mental health piece. So I wanted to pull out depression and those having this major depressive episode with severe impairment. And looking at it by age category, we can see, I thought it was pretty shocking. So 18 to 25-year-olds, that definitely stands out, with 18.6% reporting that they had a major depressive episode or one with severe impairment in the past year. And then opening up that umbrella to include, so not just major depressive disorder, but just looking at any mental illness overall, and then serious mental illness with, I'm sure we're familiar here, serious mental illness, affecting some sort of major life activity as we're comparing SMI with just any mental illness. But again, we see this category of 18 to 25 really popping out. So we have a third reporting that they had any mental illness or serious mental illness in the past year. Serious mental illness, just over 10%, 11.4% reporting that they had any a serious mental illness.
So Claire rephases her term She says that when these 18 to 25-year-olds aren't high, they're down or depressed.
I like your interpretation, Square. Okay, so switching on. So, okay, so I'm pulling in after mental illness, kind of going back to bring in major depressive disorder or episode. And now I'll cover bringing mental illness as well, but starting to bring in that co-occurring. So I wanted to note this overlap here. This is looking at the younger age group, ages 12 to 17. So 6.3 million individuals of this age group had either a substance use disorder or a major depressive disorder. Noting that overlap of 935,000, saying that they have had both within the past year in 2021. And if you look at it by the substance type, we're looking at substance use by the major depressive episode status. We can see here that those who have had a major depressive episode in the past year, they're reporting a significantly higher percentage of using substances in the past year, as well as looking at binge alcohol, as well as tobacco products or nicotine vaping use in the past month, compared to their counterparts who did not have any depressive episodes. Okay, so taking a look at the overlap of adults, so we're looking at adults age 18 or older here, of those who have reported having a substance use disorder, as well as those, those reporting any mental illness. So that, of course, includes that subset of seriously mentally ill adults. 82.5 million adults having either one of those. So SUD, substance use disorder, or any mental illness, AMI. So looking at a quarter of the population. 19.4 million have that overlap. So they are both experiencing substance use disorder as well as any mental illness. And then over on the right side here, just kind of paring it down to the serious mental illness. So 51.7 million adults having substance use disorder or SMI. And then 6.4 million with that overlap of having both SUD or SMI, and SMI, excuse me. And then taking a look at this by, let's see, mental illness, serious mental illness versus any mental illness status. So again, we see here those who are dealing with mental illness are reporting those significantly higher rates of substance use within the past year as well as past months for their respective substances shown here. And then just kind of keeping in mind, as they show it here, we have these respondents saying that they have been negatively affected by the COVID-19 pandemic with regard to their mental health. So majority of them, of course, reporting in the light blue or the red categories a little, all the way to a lot, saying that it, a lot with regard to the negative effect to their mental health. So we have, let's see, if we're looking at a little or some, you have in total, half of our adults are reporting that they perceive that negative effect on their mental illness from the pandemic. And then if you look at drug use, broken down, so the COVID-19 pandemic effect on drug use, but broken down here by age group, noting a bit of a change in this range here. So this is now reporting on the degree to which the pandemic effect was on their drug use, right? So it looks like majority of them are saying a little less or about the same when we're looking across the board here on the effect on their substance use. Okay, so that's sort of the quick snapshot of the SAMHSA statistics. I will plug their main website here. I can send that out maybe with a copy of the slides after. But there are a lot of documentation on that. You guys might be familiar, but they have a full report and then some nice highlights from the 2021 results. So that just came out, at least we were walked through it a couple of weeks ago for some of our SAMHSA recipients. Okay, so now I'm diving into looking at the emergency department discharges statewide here in Hawaii, pulling out based on ICD-10 codes, discharges that are related to substance use and mental health disorders. I did a bit of a funky, I want to say Venn diagram turned column here for every calendar year, but I really wanted to note the co-occurring substance use disorder and mental health disorders within the discharges, where at least one of them were listed as the primary diagnosis. So this is just sort of the sheer number, and I'll share just different views of this. I kind of just showed simply the crude amount, the number of discharges or the volume that's coming in to the emergency department. And then the next slides will just sort of show percentages as well as the rate per 10,000 discharges.
So we're transitioning from national data to local
now
data.
Local, correct, yes. So these are the numbers I've seen. So I'm, and kind of respective to the keeping in mind that there's been, of course, slight changes in the number of patients that we're seeing coming in for the emergency department discharges. I think it's a little better if we're doing a comparison with the per 10,000 in the next slides, but showing some numbers here. So for example, within calendar year 2020, just the crude number that I'm seeing have a co-occurring substance use disorder or mental health disorder, or at least one of those are a primary diagnosis, is 2,261 discharges. And then in the yellow, that's more pointing towards the mental health disorders, and then the blue having at least one substance use disorder diagnosis. So this is, I'm doing this just to kind of do a better comparison and sort of standardize across the years, given that there may have been a change in the number of discharges by year. So if we do a year-to-year comparison, it's nice to kind of see that per 10,000 discharge rate. And we're seeing it's slightly higher within the calendar year of 2020, as well as 2021, not as high as 2020, but certainly a little bit more elevated compared to 2018 and 2019.
So would you attribute any of the decrease between 2020 and 2021 to deaths? Or
I don't know if I want to attribute it to that. And do you have any thoughts about that? Sorry.
I would think it's unlikely. That's
okay, so maybe
but,
COVID is more likely than actually deaths. Okay.
Yeah, I think that would have an effect, at least for the elevated numbers in 2020. Having more people maybe come through the emergency department than usual.
Okay, thanks.
Yeah. Thanks, Kelly. And I want to just take a look. This is another view to look at if you're just kind of looking at the breakdown among all of your entire pool of the emergency department discharges that are related to either, and just seeing that proportion for each category. So I would say that's similar across the years. If we're looking at the co-occurring, defined by at least having one of them as a primary diagnosis, it seems pretty similar, with a higher proportion within the calendar year of 2020 being related to mental health disorders. Okay, this one pulls out the category, this sort of green portion here. I was just kind of taking a look at, okay, how many of them have a primary substance use disorder along with mental health disorder as a secondary or any of the additional diagnoses. And then that inverse in yellow, primary mental health disorder with any other additional diagnoses having at least one substance use disorder. So this is just the number of discharges. If we sort of even it out here, taking into account the volume coming through every single year, sort of evens out, but we see that same pattern of having slightly higher numbers within 2020 and 2021 compared to 2018 and 2019. And this one, I'm just clustering it by that sort of primary and secondary diagnosis status. Okay. So still seeing that sort of elevated numbers, slightly higher numbers post 2020 and after. So this one, I wanted to bring out the discharges where the primary diagnosis is the substance use disorder, and then they had an additional diagnosis of mental health disorder. Looking at it, again, we're still talking about emergency department discharges, but breaking them up to see by type of primary diagnosis with respect to, so looking at the substance use disorder type. So we have the top in the running, which is for me not surprising, but alcohol and nicotine still up at the top here, followed by other stimulants. So that includes methamphetamines, and then all the way through psychoactive substances, cannabis, opioid, cocaine, and sedatives. So this is just the number of discharges by calendar year shown in the color. So if we're sort of evening out, accounting for the number of total emergency department discharges, it sort of just pulls out that the numbers that are higher for the 2020 and 2021. And this is looking at the inverse. So emergency department discharges with primary diagnosis of mental health disorder, and then at least one diagnosis of substance use disorder in your additional diagnoses. Let's see, and then I think I pulled out the top, the most common that I've seen for the mental health disorder types. So the top being, this is just number of discharges. I've also pulled out number per 10,000 discharges. Mood disorders, I think that includes bipolar, you have anxiety, schizophrenia, schizotypal, delusional. Those are the top 3 in the running here. So top 3 mental health disorders as a primary diagnosis that it's associated with an additional or secondary diagnosis of substance use disorder. And then, so I just presented emergency department discharges, right? So looking at the hospital emergency department statewide, this one is zoning in on adult mental health division. So that's my division within the Behavioral Health Services Administration at the Hawaii State Department of Health. So we mainly see a number of individuals who, including at the state mental health authority, really anyone who, adults who have a serious mental illness. I think some of you are familiar, but we provide a range of comprehensive services from our inpatient state psychiatric hospital, so Hawaii State Hospital, the community mental health centers. We have some of our satellite locations. We have Address Crisis, right? So Hawaii Cares, Crisis Mobile Outreach, and then we have a number of contracted providers. So I wanted to pull the number of unique consumers out from our data, our avatar database, what is at least within our electronic health record system, to show which consumers, or how many of our consumers by facility type, or by service type rather, have co-occurring mental health and substance use disorders. So this is just the sheer volume of number of consumers. See, it's pretty stable within our contracted provider and Hawaii State Hospital population, slightly decreasing though with our community mental health centers. We look at the percentages compared to our entire population pool, or the number of patients, or sorry, consumers within each of these service categories. We see at least, and this is floating around 80% of co-occurring consumers within our Hawaii State Hospital. Relatively stable around nearing 20% within our contracted providers, and then community mental health centers floating around that 45% to 40% region, but on the slight decrease here as we look from 2018 all the way through 2022. And then lastly, so I don't have all the data today right now, but I tried to pull what I could with our data scientists for Hawaii State Hospital. So that's all the way on the right side here. Taking a look at how many of them are co-occurring, but then how many of those are actually involving opioids versus our non-co-occurring consumer population. So in other words, they just have a mental health disorder. So you can kind of see that there. It's just floating around, let's see, in 2018, 2019, maybe about a 10% have co-occurring specific to opioid use disorder, and then slightly less than that as we get into 2020 through 2022. But again, stressing, majority of our consumer population with Hawaii State Hospital, we are having to help them manage, co-occurring mental health and substance use disorder. I would note that this, oh, go ahead.
There's a question about the stats for 2018 stick out quite often on the slides. Any thoughts about 2018, how it was different?
For our, is this for, oh, I'm sorry, is this for adult? I don't know.
Claire, you want to specify?
Sorry guys, let me open the chat.
I think it looked like less of everything. It was a good year.
Oh, thank you, Claire. Yeah, I don't know.
All right. It's different.
Yeah, I guess, well, I was seeing it more as like an elevated.
Maybe the earlier data. Let's see. It looks like we had more.
We're comparing it by year.
Back
Yeah,
to
I'm
where
seeing lower.
a
And
good due to lack of access to care.
it could. I mean, I think a lot of it, maybe I'm sort of blinded by the increase of from 2020, and then things sort of stabilizing a little lower, but I'm going to attribute, I don't know if I can speak on the lower for 2018, but is it because we're comparing it to the higher rates from 2020 on?
Could be.
And
Go
Dan,
ahead.
feel free to
Keep going.
pop in. Thank you. Thanks, Claire. I'll get back to you after this. But yeah, I think just kind of stressing, being sort of prepared, and I think some of us are already deep into this, but addressing, right, both co-occurring mental health, substance use disorder. A lot of what our division is in the middle of it too, with for those of you who've heard Act 26, looking at, we're all seeing that same population come through the system, whether it be our health system, the healthcare system versus the criminal justice system. So we're trying to make that as one of our priorities as well, is how do we better address both, and more efficiently and in conjunction with even the criminal justice system, since a lot of us, multiple organizations and agencies, are seeing that same population pool. I was going to note one more thing about Hawaii State Hospital, and it was, we're looking at this based on the ICD-10 code, so looking at just diagnosis status, but when it comes to just general use, and hopefully we can provide an update later on, but I want to say just in the middle of we're going through a number of EHR changes and trying to get a lot of our data, which is currently being entered, maybe some of it is on paper, getting that into electronic health record system. But there is documentation that I don't have ready to present right now that's reporting more so on the substance use, not so that way we can kind of factor that in, speak on substance use and not just strictly the diagnosis from an ICD-10 code. And I think that would provide just higher rates overall. Right now, I'm just reporting on diagnosis through ICD-10 codes, but if we're looking at use, I think it's a lot higher when we're looking at Hawaii State Hospital. Okay, I think that's all that I have today. I'm going to also plug the behavioral health dashboard that a number of us are working on, including Dan, and getting help and input from the Hawaii Opioid Initiative and others. So I will pop the link in here once I'm done, but we're trying to make a lot of this data available online for you guys to pick through and slice and dice the data using an interactive platform online. So it's bh808.hawaii.gov. There's a bunch of us in the data side, and we're using multiple partners to kind of pitch into this. So including Department of Health, we're partnering up with University of Hawaii and their Data Science Institute to build this dashboard. So it's in beta mode, but we invite your feedback, right? A lot of it trying to, accurately present the data, interpret it, relies on those who are like you, who are in the field. There is a feedback form for that website. Please feel free to, ask questions, state any concerns. We are going through right now every data set and trying to upload more data sets to that dashboard to make that available for you. But I just want to welcome any sort of feedback that you guys have for us and suggestions on how to better present the data there. But thank you. I think that is all I have today. I will now hand it off, and I'll take questions. I'll check the chat. So thank you for the questions coming in. But I'll hand off now to Dan.
Great, thank you, Tiana. I have a little less to present, just going over some basic stats on mortality and morbidity in Hawaii. First, we'll look at sort of a long-term trends, how in the, nationally, and how Hawaii compares. And lately, we've seen a shifting burden for fatal overdoses from opioids, shifting from what are normally prescribed opioids to illicit opioids, heroin and fentanyl, and how maybe that shifting distribution may or may not be related to opioid prescribing practices in Hawaii. And then secondly, so that's the fatality or mortality data. But secondly, take a quick look at what EMS encounters in terms of illicit overdoses on illicit opioids, heroin, and fentanyl. Look at that on the monthly basis. And what's of interest lately is bystander administration of naloxone for those overdoses, and what we see in terms of the patient's disposition if they get bystander naloxone. So this is going, I think this is a 22-year period starting way over here in 2000 through 2021. These are the age-adjusted opioid fatality rates. And the United States, so the national rates shown in the yellow line and Hawaii specific in the red. So clearly, Hawaii has been sort of off of this scary parabolic curve that the rest of the nation has seen. We just sort of, we had a slight peak back here, say 10 years ago, and then we're more or less decreasing. We've gone up of late last couple years in terms of opioid fatality rates, but we're still, you can see this widening gap where we have 1/4 the national rate. So looking at the national epidemic, as it's often called, by the different types of substances involved in the overdoses. So the blue line is the what are called natural or semi-synthetic opioids. Those are the commonly prescribed ones. Heroin shown in the yellow, and then the synthetic in the red, and that's for the most part we're talking about fentanyl. So so over time you've seen that we've gone from overdoses being an issue with prescribed substances, prescribed opioids. As of 2014, those were outnumbered by illicit, so heroin and fentanyl combined. And then, of course, the fentanyl-related mortality really takes off in 2016, and you can see that it's still going up as of 2021. So, so that's really the issue. So that's national. And so going back to the Hawaii data, again, we didn't really see, these are the annual numbers of fatal opioid overdoses in Hawaii. And we did see this going up at an alarming rate, given our scale, but still alarming, up to about 2010, 2011. And then after that, it's really been kind of flat, again, except for maybe the last 2 years. So really, we kind of hit our peak back here in some ways. But, oops, wrong way. But when you look at the substances involved, the type of opioids, so green being the prescribed opioids and red being heroin and fentanyl in Hawaii, so that no trend is really made up of two components. One is we've seen a pretty steady decrease in overdoses in Hawaii related to prescribed opioids. And at the same time, particularly in the last few years, we've seen an increase related to illicit opioids, heroin and fentanyl. So overall, we're not really changing, but within that, we're definitely seeing a shift from prescribed to illicit substances. And of course, this has big implications for prevention. And actually touching on that topic, so going back to the deaths that were related to prescribed opioids, again, we sort of hit our peak back here, and then we were seeing this encouraging decline from, say, 2011. And that was really following what is a measure of consumption, or the number of prescribed opioids. This is US data, but Hawaii data is probably similar. So it does sort of follow that curve. And then as of 2015, we were able to acquire through the Department of Public Safety, this is showing opioid prescriptions per 10,000 starting in 2015. And you can see that this really went down, I believe, 40% up to 2021. So, you're probably aware that there were public health initiatives for more, lack of a better term, more careful opioid prescribing in the community, and we did see that in the public safety prescription monitoring database data. So this is really, we can pat ourselves on the back. This is a public health success right here.
Some people say it's gone too far. But...
Yes, thank you for that. Absolutely. And to Kelly's point, again, going back in this red, these are the deaths due to illicit substances. So heroin and fentanyl, that's sort of gone the other direction. So is this causing this, basically, is the question that we have to ask. I like to think it's not like a one-for-one sort of relationship. I think this is just me maybe wishful thinking, but I like to think overall we made some gains on a public health perspective. Undoubtedly, we have people who are suddenly do no longer have access to their prescribed opioids and are turning to fentanyl and heroin.
And do you have a couple of questions?
Yes.
Actually, they're coming in fast now. How many of these opioid related? Oh, how many of these are opioid related versus single substance fatality alone? Do you go into that later?
I do not. It's a good question. And I can look at that from, this is all death certificate data, by the way. And I can look at it from the death certificate side, and I'm kind of going off memory, but there are a fair amount that are opioid only. How's that for you? A fair amount. I can't really, it's probably 40% or so. But the work that Tiana is helping to lead within the department can really put a number on that, because it will acquire the actual toxicology results at autopsy. And, there's some nuance there. Like sometimes a person can be positive, for example, to cannabinoids or meth, but the pathologist will not include it as a contributing cause of death. So, it's a little bit difficult to interpret, but it's a good question. I'm sorry I don't have a better answer for you, but it is a topic that we anticipate getting better data on coming up.
Do you think some of this decrease in mortality is from naloxone?
Absolutely, I do. This is only going through 2021, and in just a couple of minutes, we'll go over some of the EMS data that shows that naloxone, bystander naloxone, is being increasingly used in the community. So that's absolutely a lifesaver.
There's your good public health piece.
Yes,
good.
it is.
Yeah,
absolutely. That's sort of a harm reduction approach, but absolutely, the more you can get that out in the community, the more you will prevent fatal overdoses from becoming fatal.
And then there's just two more things. There was a few people commenting on there's a lot of patients not getting narcotics that need them. They're getting calls every day. So that's what made me say maybe it's eased us too far down. But Sue asked a good question, and I hadn't heard this before. A mother recently informed me that the FDA does not recommend babies be exposed to fentanyl or fentanyl used during labor and delivery. She informed me fentanyl epidurals are common. Any thoughts on short or long-term impact on this cohort? And that's probably more a question for everybody, so we can go back to it at the end. But
Okay.
yeah, I hadn't heard that.
I hadn't either, and I appreciate the out on ducking that question because I don't know anything about it. But I don't, certainly in terms of fatal overdoses, we don't see infants or toddlers in the state as yet.
All right, go ahead, and then I'll ask more at the end.
Okay, yeah, appreciate it. But your other comment, Kelly, preceding that was going too far in terms of restricting opioids, prescribed opioids, and undoubtedly that's what's going on. This is me on my little soapbox here because I'm not a doctor, so but there's certainly room to, I mean, the guidelines were put out there, they were promoted. There is some what would you say, it's not enforcement, but it's sort of, I know public safety is contacting providers who are over the recommended daily allowance.
They're sending folks to jail. We've had a couple doctors in Hawaii go to jail. Now, I don't know the specifics, so I don't know if that's right or wrong. It's probably perfect.
Yeah,
right. Yeah.
I don't either.
I do know as a physician, I'm afraid to prescribe too many because they'll come look at me, that kind of thing. So it's kind of like put the fear of the government into the medical offices. And if only certain people will prescribe, I don't know.
No, it's true. But there is, there's language in the guidelines that you can essentially keep patients on the same level, even though it's higher than the recommended amount. As long as as you probably know as a provider, there are plenty of consumers that are at relatively high doses that are probably not at risk for overdosing. So there's kind of, I don't know, again, it's kind of a nuance, which we don't do very well in public health, I will say. We generally, we try to keep the message simple, but here's an area where there really needs to be some, not punitive follow-up, but just, that room to keep people on their functioning levels.
And Carmen
if in your clinical judgment, they're not at risk.
Right. Carmen points out that there is no limit because the CDC removed the limits in the last revision. Everyone's tolerance is different. But the fear on the provider's part, we haven't found the sweet spot yet. I think we've over-regulated and more to do. So anyway.
No, thank you. And thanks, Carmen. She's always really on top of these things. Appreciate it. Good discussion. Thanks. Okay, so that was the mortality data. And then this is what EMS encounters statewide. We had a revamped EMS data collection system, which more or less went into practice in October of 2021. So we have data from then until just last month, where this is the monthly number of EMS patients with an overdose from fentanyl or heroin. And heroin here is shown in the blue and fentanyl in the red. And again, we are seeing this increase as of, say, September of last year for fentanyl-related poisoning. So, going back to the beginning of my slides, we were kind of off that curve in terms of synthetic opioids or fentanyl in Hawaii, but it looks like we're finally, as everyone predicted would happen eventually, fentanyl is becoming an increasingly commonly used substance in Hawaii. So that's the monthly number. Again, kind of if you combine the two, no real clear trend, but within this last, say, 3-4 month period, you can see how related to heroin are going down as those related to fentanyl are sort of are increasing, particularly lately. Okay, last thing to go over here is these EMS patients with illicit opioid overdoses and what we're seeing in terms of bystander naloxone. So this is pre-EMS naloxone. Obviously, when EMS gets there, they will generally give the patient naloxone, but pre-EMS, over this time period, a little over a year, about 1 in 4 of these patients got bystander naloxone. Roughly equal numbers from 11% from, well, 10% from a first responder, so fire or police agencies, and about the same amount from mostly the patient's friends and a smaller component of the family members of the patient. And we don't know for the remaining 3%. So overall, about 1 in 4 got bystander naloxone. That was more common for patients on Kauai County, 44%, in Maui, about 1 in 3, and lower for Oahu and Hawaii County, more like 1 in 5. But it is increasing over time, almost by month. So since April of 2022, it's been more like 1 in 3 of these patients got bystander naloxone. And in terms of their outcomes, they, spoiler alert, they do better if they got the bystander naloxone than if they did not, which is this group over here. So basically, the ones who got bystander naloxone, 35% refused transport from the scene. So you fall over, unresponsive, your buddy's there with the naloxone, EMS gets there, and it's like, oh, I don't want to go to the hospital, even though I nearly died from it. Anyway, whatever. So 1 in 3 refused transport to a hospital if you got bystander naloxone versus say 1 out of 10 if there was no bystander naloxone. So
they better hope their buddy has another shot to give.
Yes, thank you.
They're going to send EMS away.
Yeah, EMS often gives, I'd say, more than half of their encounters give more than 1 dose. So.
Okay, so lots of fentanyl questions. Is fentanyl cheaper than heroin on the streets? Does anybody know?
I think it is. Is that what Rico's been telling us, Tiana?
I was going to say the same thing. Yes, that's what per the high intensity drug trafficking area for Hawaii.
Because you don't need much at all. Leilani says one of the big issues is that people do not know there is fentanyl in their drugs. So the news that fentanyl test strips were being given out to the community since 2018 are actually seen as illegal. Oh, the news that happened is horrific. No reason for it. It absolutely saves lives to test drugs because it gives people information they need to make a choice about their drugs. So this is something that is being debated all over the place. But we thought about giving out fentanyl test strips to folks so that they could test their drugs and make sure there was no fentanyl in them. Well, if you are arrested, fentanyl test strip can be seen as, what's it called? Substance paraphernalia. So it can make you more likely to go back to jail, even in Hawaii. And so some states have, Ella says, better safe than sorry, though. Yeah, so some states have passed laws that fentanyl test strips are not drug paraphernalia. I don't believe we've done that yet, and I don't know if it's going through this time. If anybody's, I hope somebody's done that.
I have a question on that. I posted one of our HOI meetings maybe 6 months ago when this came up, that Biden announced, I think it was April 2021, that anybody receiving federal funds could use them for test strips. I posted the link, and so wouldn't the OD2A qualify?
You would think.
Yeah, Carmen, I'm actually asking around about that now, since that came up in a meeting I had with UH yesterday. But yeah, my understanding is that the federal grants, those projects are supportive, but there's a question as to where that lies in the state level.
I always
But-
thought federal superseded state.
Well, it's
Yeah, I'm
really
not-
for the individual when they get arrested. Can they show where it came from and all that? You know, it's just kind of
President-
crazy.
I don't know.
Yeah.
Yeah, okay.
Leilani says she ran the statewide syringe exchange for 6.5 years and not knowing that they were illegal saved lives. How reliable are the fentanyl test strips? I thought they were very reliable, but I can be naive on things. Does anybody know? I mean, they're just positive or negative, I think. You don't know how much, you don't know anything, you just know there's fentanyl in there. Now, I heard a downside of this is that some people are using them now to make sure that the drugs they get are fentanyl.
Mhm. Yeah.
We've got all kinds of fun here.
Yes. Going back to the legality, I think there's differs across our 4 counties in the state, but I believe I've heard law enforcement say that they're in favor of making it not contraband. So hopefully there'll be legislative initiatives if they're required. But I
Yeah.
think they're mostly on board with they being law enforcement agencies with it as a sort of harm reduction approach.
Yeah. Does EMS give bystanders naloxone for those patients who refuse transport? That's a good question.
They do not. They will. I've read a few notes where, I mean, EMS will try really hard to convince someone to get in the rig and go to the hospital. If they adamantly refuse, they will just, again, give them caution and say, you know, you could become unresponsive again. But that's about it.
Now, we can all go into a pharmacy and pay for naloxone, but some pharmacies will give you attitude. Let's see. Test strips do not tell you how much fentanyl are in the drug, unfortunately, but it's very sensitive and will tell you if there's even a trace amounts. All right, go ahead.
Any other questions?
There is one.
Okay.
It would be of interest to compare stimulant drug use to opioid drug abuse in Hawaii over the past 5 to 10 years. I suspect that the fentanyl epidemic has not yet arrived. This was a while back in the talk, and it's getting here. Do we have stimulant versus opioid?
Yeah, not in today's presentation, but it's magnitudes higher, meth-related mortality compared to opioid in Hawaii. And we are somewhat unique as a state in that regard. I think we have the second highest mortality rate in the country, if I'm not mistaken. So it's absolutely, I mean, no one wants to say they forgot about meth. It certainly never went away, and it's an ongoing concern. But it did not, from a public health perspective, it did not get as much, from what I see anyway, did not get as much funding support as opioids did of late and currently.
The feds are just figuring out that everybody has meth, and meth is dangerous too.
Yeah, no, I mean, Hawaii, everyone knows this, right? Nationally, it's because it's an increasing issue, but it's, like I said, Hawaii has always been on a different curve in a bad way compared to national in terms of meth. So, and to be honest,
we're ahead of the curve for once.
Yeah, yay. And another thing I'll mention about meth is the highest mortality rates we see in our state are in basically my age group, so 40 to 60 plus year olds. So I really think people have probably heard me say this before, but I really think it's kind of a cohort effect for long-term meth users going back to the 80s and 90s in Hawaii that eventually die from that, you know, those long-term insults to the cardiovascular system mostly. So. Okay, let me just wrap it up. So, you know, Hawaii, we did have low rates, but right here, but we do have a high rate for meth-related overdoses. And within our state, we're seeing increasingly more overdoses related to heroin and particularly fentanyl. You know, that's on the order of say 40 to 50 deaths a year, but EMS sees at least that many on a monthly basis. You know, 97% survive their overdose, thankfully. But lately, that's also, we've seen fentanyl sort of overtaking heroin in Hawaii in the last 3-4 months. And we are seeing these encouraging trends in terms of use of bystander naloxone, and also, you know, we're seeing improved patient outcomes for those folks who do get bystander naloxone. So that's also encouraging.
Excellent. Thank you so much. Did some people believe meth use may decrease contracting COVID? I certainly hope not. And speaking of COVID, next week we have non-acute sequelae of COVID. So it is on your request for a long COVID discussion. And then we had one other question, or one other statement here. We do not have a drug like naloxone to give meth users in Guam. And that is criminal. So any behavioral health grant that you guys write could include naloxone, and you should be able to get some. So anyway, excellent talk. Thank you both so much. We had, what, 120 folks or something like that listen to you.
Great.
And very informative. As Summer put in the chat, the slides will be up online at the HawaiiEcho.info website. Great talk, and we'll want to have you back next year to tell you how we've improved everything, right? Make sure you look in the chat for all those thank yous. They just keep coming in. So thank you again. And thank you for all your help on everything. Regular help for us getting opioid grants. Thanks for the information, guys.
Thank you. Thank you, everybody.
Thanks, everyone.
Yeah, wonderful
Having
job.
us.